Okay, so these are the adjustments for the final practical. So for the occiput, you're gonna motion it out. So you're gonna place a finger on the mastoid and a finger on C1. You'll rotate and then push into end range. So check both sides, mastoid and C1. And then there's a restrictions, left rotation restriction. So you'll set up on the right side. So you'll slide off the mastoid onto C1. Patient slide down a little bit, down a little bit further. And then I'll have my fingers pointing towards the face to help with my adjustment. Laterally flex, rotate a little bit, and then thrust across the line of the shoulders, making sure that the patient's head is in my strike zone. So I'll just set that up one more time. So you slide down and off. Laterally flex, step out, away from your work, rotate, and then drive across L to M. Next is supine right TMJ. So patient will be lying supine on the table. And to check the TMJ, you can place your fingers over the joint and then just have the patient open and close their mouth. Feeling for any clicking or discrepancies when they do that. You can also watch jaw gait when they do this, looking for any deviations or catches. So I'm gonna rotate the patient's head to the left. I'll be placing my piezoform on the jaw. Patient's gonna open their mouth, and when their mouth is slightly open, I'm gonna thrust kind of into their axilla, so across, pushing for long axis distraction of the jaw. So next is thoracic, so I'll have the patient sit up at the end of the table. I'll have the patient place their hands on their shoulders, on the back of their head. I'm gonna grip under their elbows, open up your gown if that's okay. And then I'll be motioning up the thoracic spine to check for any restrictions. And then I can motion for rotation as well. So rotating and then pushing, overpressuring on the TP. So there is a T6 right rotation restriction. So patient is going to be lying prone, so on their stomach. I'll be on the side patient, I'm going to open up your gown. Define T6, inferior angle of the scapula into the middle, T7, up one segment is T6. I'm going to place my hand on the segment and then I'll torque the segment to help with the adjustment. So breathe in, patient. And then all the way out, and on their full exhale, I'll deliver a thrust P to A through my hands. Next is supine right glenohumeral internal rotation. So patient is going to be lying supine, and then to check for internal rotation, you can check the range of motion of the arc. So I'll have the patient have their hand here, and then they'll just drop it into external rotation and then into internal rotation, and you want to see 150 degrees total. And if you don't see that, the internal rotation restriction here. So I'm going to place my knee with the patient and my arm over top of their arm to help induce internal rotation. I'll rotate them to get them to their end range, and then once I get there, I'll impulse. Then you'll rotate them further, impulse again, rotate further, and impulse again. So you're looking for 3 to 4 impulses to help induce internal rotation of the shoulder. Patient's going to be seated now. We'll check the motion of the radial head, so you can face that way. So to check radial head motion, you'll palpate the radial head with your thumb, and then you'll move them into flexion and extension of the elbow. You can also do some pronation and supination to check motion. Then once you find the restriction, you'll place your thumb over the radial head, pronate, and then once you get to end range, you'll deliver a P to A thrust through your thumb into the radial head. Standing behind the patient. So carpal's on the right. So proximal row. So you'll locate the proximal row of carpals and you can check for flexion and extension restriction just by palpating throughout. Then you'll block the distal row, and then your other finger will be over the radial ulnar joint. And then you'll have the patient lean away. You'll give long axis distraction, and then you'll deliver a thrust P to A through the proximal row of carpals. TL junction, so patient sit. So to palpate the TL junction, you can palpate from behind the patient. So I'm just gonna open up your gown, so skin to skin palpation. You'll push them into extension and end range, checking for any restrictions. And then you would place a thoracic board on the table. We don't have one in this room. It would be just behind the patient so that they aren't sitting on it. You'll have the patient cross their arms over. You'll place a closed fist in the segment that's restricted. Have the patient breathe in, breathe out, and then you'll lay them down over the thoracic board and deliver the thrust once they've finished their exhale. Thrust would be A to P through the segment. So internal rotation of the hip. So patient's gonna be lying supine. There's a few different ways that you can check internal rotation of the hip. So you can flex the knee up and rotate them around, checking for any restrictions. So it's pretty restricted there. You're gonna come to the end of the table with the patient's legs straight. You're gonna take your hand on the outside of the ankle, wrapping it around to grab the inside of the ankle, making sure that you're keeping your body in good biomechanical position. You'll reinforce with your other hand, lean back, and deliver a long axis distraction, making sure that you keep the leg in internal rotation. So fibular head. So patient can stay in this position to check it. You'll make sure that the knee's slightly bent. I sit on the foot to make sure that it's stabilized, and then I hook behind the fibula, pulling P to A, and then I use my thenar contact to push A to P, checking for restriction. So have the patient flip over onto their stomach. Come to the other side of the table so that you're still on the right side. Have the patient bend their foot up. You're then gonna make sure that their foot hooks onto your shoulder. Take a piezoform contact, drag it onto the fibula, reinforce with your other hand. Long axis distract up, and then pull towards you P to A to correct the restriction. And then right MCP. So patient, I'm gonna have you lay on your back. I'll get you to take your right shoe and your right sock off. And then I'm gonna be taking like a pincer contact with my finger. I'll grab the first toe, reinforce the ankle to make sure that it stays, and then you can just check motion, twisting both ways, and then plantar and dorsiflexing. And then whichever way you find the restriction, you would then just send an impulse. So if I'm going up, I would impulse up into dorsiflexion, down into plantar flexion, and internal or external rotation.